So today we're talking about cognition and perception. Your lesson objectives are listed here. So stimuli. The environment excites or stimulates the senses. The senses in turn pass these stimuli to the cerebral cortex where recognition or perception and interpretation or cognition occurs. Specific regions of the cerebral cortex are responsible for detecting and processing the stimuli acquired by the various senses. If we have a malfunction of the sensory organ, the interpretation centers of the brain may receive distorted perception or cognition. So if the senses don't function properly, stimuli can't enter the brain, or there may not be enough information for accurate interpretation. A person that has sensory deficits in one area may attempt to compensate for those deficits by gathering more information from another area. An example would be a person that is blind may get additional information from their auditory senses. Our cognitive ability is based on our senses, and we have a number of changes that occur as we age. Common visual changes include farsightedness. This is caused by a loss of elasticity of the lens and results in a decreased power for accommodation, or presbyopia. We also see a decreased ability to respond to changes in light, and this results in night blindness. We see cataracts, which cloud the lens and result in blurred vision and sensitivity to glare. We also have a number of auditory changes with aging. An older adult is increasingly susceptible to misinterpretation, misperception, misperception when there is one or more changes present. Common auditory changes include loss of hearing acuity, particularly in higher pitch sounds, and this is called presbycusis. Loss of hearing resulting from decreased sound transmission, and this is called otosclerosis. We may see ringing in the ears or tinnitus, and this can be caused by the disease process such as Meniere's, just age-related changes, or medication. Again, this makes the older adult increasingly susceptible to misinterpretation, misperception, and misunderstanding. Here's a question for you. People who have visual deficits rely more heavily on which sense? So cognition. We said cognition or thought takes place in the cerebral cortex of the brain. Cognitive development starts at the time of birth, or perhaps even earlier. We know that the neural tube begins to develop at about week 4, and this will close and separate into the brain and the spinal cord. When the human brain is repeatedly exposed to stimuli, connections develop between nerve fibers in the cerebral cortex. Each time the stimuli is introduced to the brain, they are associated at an unconscious level with a pool of facts, memories, and experiences that are stored there. Once these connections are firmly established, information is said to be learned. Once learning has taken place, information or skill can be retrieved as needed. Memory enables people to retain and recall previously experienced sensation, ideas, concepts, impressions, and all information that has been previously learned. The human mind is extraordinary in its ability to learn and process extensive amounts of information. It's able to retrieve information on demand, correlate random pieces of information, make judgments, solve problems, and create ideas. Cognition and intelligence. Oftentimes, we talk about a person's cognition and relate it to their intelligence. However, IQ can be deceptive because there are different types of intelligence, and standardized testing procedures do not measure all types of intelligence. Fluid intelligence is the ability to perform a task or make judgments based on unfamiliar stimuli. This is sometimes called thinking on your feet. Crystallized intelligence, often called wisdom, is the ability to perform tasks and make judgments based on knowledge and experiences acquired through a lifetime. We see this much more often in our elderly. Because young people have less knowledge and experience, they may rely more on fluid intelligence. Our intelligence is often measured by means of testing. These tests have some distinct limitations. Most written tests measure verbal and mathematic ability. Thus, a person who has had little formal education can have a high level of cognition, yet score poorly on these standardized tests. Cognition is not the same as education. Cognition is the ability to think and reason. Many people have good cognitive skills but limited education. Also, intelligence tests are normally timed. Again, we know that as we age, our ability for recall declines. Therefore, these tests may not accurately detect cognition or cognitive ability in our elderly population. Cognition and language. Many older people who are considered confused actually suffer from disturbed sensory perceptions. Language is a product of cognitive function in both spoken and written form. Language allows us to communicate, and it's developed early in life. By the age of 2, the average child has a vocabulary of several hundred words. Very specific areas of the brain are dedicated to language, and they change significantly as language skills improve. Sensory and cognitive problems can result in poor language development or loss of language skills. Damage to the language centers of the brain can result in aphasia, a condition where the person is unable to understand or express themselves through language. So we said that sensory info may be misinterpreted or misperceived due to a disorder. Some possible indicators of hearing loss which may affect sensory perception include the following. Intelligence does not automatically decrease with aging, nor does our ability to learn. Some people seem less intelligent as they age because their tendency to be slower and more cautious in their responses. Rather than be embarrassed, older people often take more time to be certain of their answer before they respond. Their hesitancy or uncertainty may be mistaken as a lack of intelligence, which it is not. We also talked about earlier the lack of formal schooling may make older people appear less intelligent. They may lack polish in their speech and have a more limited vocabulary than better educated people. Many older adults who grew up in difficult times ended their formal education at a young age because they had to work to help support the family. When today's older adults enter the workforce, advanced education was not needed to earn a living. Many continued to read and learn and often exceeded what school would have provided. Still, these older adults may be intimidated by young, well-educated caregivers. Memory loss. There are no known reasons why memory loss happens, but nearly 13% of those over the age of 60 surveyed reported memory loss. The speed of information processing and recall by the brain changes with aging. It's common for that older adult to take longer to recall a specific piece of information. Short-term memory is more likely to be affected than long-term memory. An older person who cannot remember what he or she had for breakfast may be able to describe in great detail an event that occurred 50 years ago. Some degree of forgetfulness or memory loss is common with aging. This problem can be disturbing to the alert older adult. Many begin to fear that they are losing their mind or developing a serious problem. So we need to carefully assess to distinguish mild memory loss as an early indication of a more serious cognitive disorder. The more memories a person has developed throughout life, the more he or she will retain. So well-educated older adults tend to retain a higher level of functioning than do less well-educated older adults. Even without formal education, many older adults are able to compensate for memory gaps by relying more on their large pool of experiences which they have gathered over a lifetime. Cognition is the same as education. Is that true or false? So if we were to evaluate our person for disturbed sensory perception, our assessment or data collection would include the following questions. When an older person has a condition which a portion of the visual field is lost, it is called. So cognitive changes. We said that memory loss, mild memory loss, may be part of normal aging. Anytime there is damage that interferes with normal functioning of the cerebral cortex, it can result in cognitive problems. All changes in cognitive function must be given immediate attention. Prompt assessment of the type and severity of disorders along with identification of the causes or cause enables the caregiver to plan the most appropriate interventions for each individual. Cognitive functioning can be affected by sensory changes, physiological factors, or emotional disorders, and cognitive problems can range from mild or reversible forms of disorientation to severe and irreversible forms of dementia. Depression, hypothyroidism, and vitamin deficiencies are common treatable causes of pseudodementia. Sensory changes can result in behaviors that mimic cognitive problems, but actually are not. The two should not be confused. Sensory misperceptions should be ruled out before further cognitive assessments are performed. So we need to distinguish between confusion or delirium and dementia. The term confusion is used to describe a wide range of behaviors. Confusion can be defined as the mental state characterized by disorientation regarding time, place, or person that leads to bewilderment, perplexity, lack of orderly thought, and an inability to choose or act decisively and to perform activities of daily living. And this can be caused by a wide range of problems. When we talk about acute confusion, oftentimes it is because it is caused by a physiological process that affects the autonomic nervous system. Conditions that can cause delirium include uncontrolled pain, infection, metabolic disturbances, vitamin deficiencies, uremia, hypoxia, hypercalcemia, endocrine imbalance, myocardial infarction, constipation, drug toxicity, and drug withdrawal. A mnemonic to help you remember delirium includes the word delirium. D for drug use, E for electrolyte imbalance, L for lack of drugs, I for infection, R for reduced sensory input, I for intracranial problems, U for urinary retention and or fecal impaction, and M for myocardial problems. Remember that acute delirium has a sudden onset of hours or days. It is characterized by rapid mood swings, disorganized sleep cycles, changes in psychomotor activity, either hypoactivity or hyperactivity or both, tremors, spasmodic behavior, rapid speech patterns, loss of attention, and a wide range of cognitive changes. We figure out and treat the problem, and oftentimes this confusion will go away. We have talked about dementia in a number of our classes, and this is a slow, insidious process that results in progressive loss of cognitive functioning. Dementia is caused by damage to the cerebral cortex. It's the most common result of this condition is Alzheimer's disease. Other common causes include vascular dementia caused post-stroke, drug intoxication, Huntington's disease, cerebral hypoxia, hyperthyroidism, subdural hematomas, and brain tumors, which are less common. Recently, there has come to light strong evidence linking dementia with anticholinergic drugs that are used with older adults, a category of medications that are consumed by up to 20% of our elderly. With dementia, we see changes in memory, judgment, language, mathematic calculation, abstract reasoning, and problem-solving ability. Changes related to dementia are progressive and irreversible. In the early stages, dementia may be mistaken to be considered part of normal aging, and that can result in a delayed diagnosis. On this slide, there are two videos that detail information and what happens and what dementia or what Alzheimer's feels like. Because it doesn't work to include a link in these videos, please copy the URL into your computer browser and view these videos. So these would be nursing interventions for a patient with confusion, such as that found with dementia. When dealing with an older adult who are hearing impaired, it is useful to speak in a low tone of voice because hearing loss is usually in the higher frequencies. Is this true or false? Nursing interventions for pain. The origin of some stimuli, such as pain, is within the body. Either physiological damage or psychological distress can result in a sensation that we call pain. Pain is subjective. It is what the person tells you it is. Everyone experiences pain in a unique way because no two people mean exactly the same thing when they say they have pain. We need to attempt to detect and determine the severity of another person's pain through careful assessments. We can neither see pain nor measure pain with a meter, but we can detect its presence by careful listening and observation. Much information regarding the severity, quality, and location of pain can be gained from listening to how the person describes his or her pain, observing the individual's level of activity, and watching body language for subtle cues such as grimacing, guarding of a body part, or drawing away from a body part when it is touched. Various visual pain scales can help determine the severity of pain. And your last slide. Agitated behavior, which are often worse late in the day, are referred to as